what I hope to achieve now is really out of practicing this area every day of the year, talking to about 200 women and their health professionals a year, to go with you into the real issues, some of the big gaps. Some of them were covered by Dawn very aptly, and I will not repeat it. But here is some of the issues as I see it, standing in a clinic that talked to a lot of Canadian and American women. This huge anxiety of birth defects, that leads women not to take medications very often, even if it's for life-threatening conditions. That's a big issue that we'll have to address. Of course, the same type of anxiety translates to pharmaceutical anxieties. Drug companies typically don't want to touch a medication in pregnancy with 10-foot pole. And even if they recognize on a personal level that it's important, for legal reasons, they will not touch it. And it's a big issue. As a result of those, of course, very few drugs are indicated for pregnancy. Now, those of you practicing pediatrics or obstetrics know that most of what we give to children or pregnant women are not labeled for that. Now, that does not mean that we cross lines, because we practice based on what our practice guidelines are. There are many other levels. But it means that the appropriate studies were not done. And here is an example of that the SSRI that was mentioned before. Even if you are very afraid of malformations, physical malformations are created in the first trimester. You'll be surprised how many women discontinue the medication in the second trimester after the drug cannot even do something, or even if it has the potential. So these are some of the examples of the issues. We'll hear later on the thalidomide organization in Canada, but of course, to some extent, I want to go back to the thalidomide experience, because it was when that area came to our mind in such a painful and powerful way. Thalidomide is back on the market now for a couple of indications, and there are systems now to ensure that it's treating women but without exposing the fetus. I would want to say that the thalidomide disaster in one way increased our awareness that we have a major issue, but it caused many physicians and women to believe that every drug is another thalidomide, so they won't take anything. And this figment of the thalidomide in many ways took out of many people the rational thinking about medications in pregnancy. And that's a major issue. And that's a perception of risk. When we started the Motherisk program, I thought we will mostly prevent malformations. But soon it became very clear that we are preventing a lot of discontinuation of pregnancy, abortions. Women are already booked for abortion because a neighbor, a mother-in-law, a physician told her that this medication is not good, she should terminate pregnancy. So we began to ask women about how they perceive risk, and I was shocked to find out that about 25% of women taking non-teratogenic drugs, say acetaminophen, dental x-rays, things which are not causing problems, are sure that they have 25% risk of malformations. 25% is about the risk of thalidomide. So out there, women believe they have huge risk, and we did studies showing that the same figment is with physicians too, pharmacists and other health professionals. It's not unique just to the woman. Now, we also showed that with evidence-based counseling, when you talk to women who are already booked for termination, you can change their mind in most cases and lead them to have a healthy child. So that kind of highlights the issue of perception. I'm sure many of you remember the Chernobyl disaster, where the Ukrainians were filled with atomic waste because of a nuclear plant that went wrong. After the Chernobyl, many, many miles away from Chernobyl, in Athens, Greece, half of all pregnancies were terminated in that week. If you want to read something amazing, go to the BMJ of 85. And this is written by the reason was that Greek doctors told the woman they have huge risk for malformation in this child. The risk was zero, actually, in Greece, about zero. At the same time, about 45 Canadian women happened to be in Europe, and they called Motherisk, which led us to look into it, call Atomic Canada, any other agent that could help us to find out that the amount of radiation that the women who were not in Ukraine were exposed equaled 10 to the minus 27 of one X-ray. So clearly nothing that you can measure. Still, the figment of a huge risk, a shadow, led many people. The risk of the wrong perception was by far larger than the risk of the exposure itself. And that's a big issue. There are other examples that I'll go very briefly. There are drugs that are teratogenic in animals, the quinolones. Quinolones giving to dogs, pups, to mums in pregnancy will cause arthropathy in the pups. But guess what? Children are not beginning to walk on 4 when they are born. And studies fail to show any risk to babies when mom took quinolones. So here's an animal teratogen that is not a human teratogen. And still, women tend to terminate pregnancy because they took quinolones. The same is true for rubella vaccine. Rubella vaccine, there is yet a single case to be described in the literature of women who received rubella vaccine in pregnancy and had a rubella syndrome in the baby. Not a single case. Yet, women tend to terminate their pregnancy, even when they come to Motherisk. 7 of 94 we could not pursue not to terminate, because someone told them that rubella is not consistent with continuing pregnancy. The third example is, of course, the radiation. In a study published by us in the Canadian Journal of Obstetrics and Ecology, we show that despite women coming to Motherisk, 7 still terminated pregnancy. They said, well, you tell me, you're assuring me that radiation in the way I was exposed is not a risk, but I cannot change. I'm such high level of anxiety. I suspect that women who do not get that counseling, the levels are much higher, levels of women who terminate pregnancy. Now, one approach that was actually examined recently in a pilot manner that I want to share with you is trying to empower women to be treated when needed. When a drug is safe in pregnancy, and we will discuss that in a minute, and there are drugs that were shown to be safe, even with good epidemiology. The example I have here is Bendectin, the drug for morning sickness. The company reported to us that they, and that's actually on the market, I believe the next picture will show it, the tablet have an indicia of a pregnant woman. And what the company did through studies that they handled, they show that if they show indicia on a tablet to women, they perceive much lower risk than if you don't show indicia. So actually, I believe it's the first company in the world that includes now indicia on the product as a means to empower women to take a safe medication, to overcome the shadow I was talking about before. This has to be studied more, and we intend to study it in the future. It's an example where you can do something to change women's ability or compliance with medication. So this is a very exciting, new or novel way to approach this sciences involved here. Because you have to realize we are not just talking about biology and biology. We are talking human behavior, which is a much more complex science. People don't do what you think they do. We don't do what we think we do. Let me talk about the nausea and vomiting as a model drug, model condition. This occurs to 80% of pregnant women, so clearly it's more the normal than the abnormal. The drug Bendectin, a combination of doxylamine, an old antihistamine, and pyridoxine, vitamin B6, was used by 40% of American women, and indeed many Canadian women, in the late 70s. But then more and more cases came to court blaming that the drug caused limb defects and cardiac defects and brain defects. Anything under the sun came to the court. Lower courts awarded millions of dollars, all of which were rejected in the Supreme Court. And actually, the American Supreme Court not just rejected it, but also established based on this what an expert witness should be. So this was a really important case. But the company could not hold the cost of litigation. Their insurers say, guys, no game anymore. And as a result, here is Bendectin removed out of the American market. This fall here is because of the litigation fears, but in 82 it's removed. If it caused limb reduction, then the limb reduction should come down, as happened with thalidomide. That did not happen. So here, if you wish, is ecological proof that Bendectin did not cause it. But do you think that American and Canadian women stopped vomiting when it was taken off the market? Not just that they did not stop, the rate of hospitalization of women, both countries, after the drug was removed, it was the only drug approved for morning sickness, more than tripled. So more than threefold more women need to be hospitalized now for morning sickness because there is no medication approved by FDA. As some of you may know, Canada has a very proud chapter on this. We're talking about the two countries. While Bendectin was removed from the American market, Diclectin, which is a generic Bendectin, was already on the market. The drug was beyond its patent. And in 88, Toronto Star published a Saturday Star, where everyone has time to read, I'm sorry I don't have it to show you, saying a drug feared thalidomide still on the Canadian market. That was the headline. It took 2 days to hit the Parliament floor in Ottawa. The Minister of Health of that time, who was then the Premier of Quebec, appointed a committee, and very wisely it brought American and Canadian experts that told him that the drug should be on the market, not just should be, but be indicated, not as a last resort, so you can support physicians, pharmacists to use it. And that happened. And not surprising, during the 90s, Diclectin is used more and more. And look what happened to the rate of hospitalization of Canadian women. As a matter of fact, these new graphs where this figure is even lower. So while in the United States hospitalization is still high, in Canada it's coming down. This is not a causal proof that Diclectin did it, but we cannot find anything else that happened during that time period to explain less hospitalization. One may argue there is more home care, for example, but actually home care lags very much behind. It's not largely used. I want to use another example of a drug to show you the other hand. Leflunomide, Arava, is a revolutionary drug to inhibit de novo pyrimidine synthesis, and it's used in rheumatoid arthritis. It's really a niche drug that changed the life of a lot of people with rheumatoid arthritis. However, the animal studies showed major malformations at levels in the plasma that is achieved in humans taking the drug. In other words, if you are pregnant and you take the drug, the animals show huge level of malformation. Needless to say, that led to very sweeping labeling that you cannot be pregnant to it, you have to avoid pregnancy. If you happen to be pregnant, you have to counsel and there will be malformations. Only when the first prospective study began by the Organization of Teratology Information Services, which is American and Canadian services, no malformations were found, I believe now, with over 50 cases receiving the drug. Of course, the drug was not given to them as part of the study, but these are women who failed contraception. There were no malformations. And why is that? Because in animals, in this particular case, tyrosine kinase associated with this process, much more sensitive to leflunomide. So here's an example that the animal studies are not relevant to humans. And that's the type of science we have to collect. You cannot extrapolate easy among species, which means, sadly, that women will need to be their own guinea pigs. or we will need to be our own guinea pigs. I'm not saying it cynically, but that's why we need to collect human experience. Let me touch upon the depression of pregnancy, as was mentioned by Dawn and one of your participants. Depression occurs to up to 20% of pregnant women. Many times we don't know because we don't ask and we don't do what needed to detect depression. But when we started in Motherisk using validated tool to talk to women, I was shocked how high it is. And in our program, Irena Nullman is running a large number of studies on the effect of SSRIs, which appear to be safe during dysmorphology and neurobehavior. And these are a series of studies. Irena just finished a new study when venlafaxine affects her. These recent evidence published about Paxil and other SSRIs but associated in a case control study with more persistent hypertension in the pulmonary hypertension. The authors concealed that even if they are correct, the effect will affect less than 1% of treated mothers. What the paper does not transcend and what most readers don't understand, PPAH is not a name of a disease, it's a syndrome. It's caused by so many different reasons, many of which are actually going away. Some of them are not, especially with cardiac malformations. Not in the paper, but I found it by calling them. That's exactly where you need to do some time more. They tell you that 3% of these case controls with hypertension died by the time they interviewed them, which is what you expect with such a syndrome, especially when it's associated with cardiac malformations. But I asked them, how many of those who died were on SSRIs? None. How come it's not in the paper? It's not in the paper. So, you see, this is a syndrome, and this syndrome occurs maybe to 1% of exposed, but it caused the FDA and Health Canada to issue statements that did not never mention the risk of discontinuing therapy, and I'll talk about this in a minute. We describe in 202 neonatal discontinuation syndrome, self-limited, occurring with SSRIs. This was repeated by 5-6 other studies from Sweden, from the United States. This is not surprising. If you are an adult taking the drug and you stop it cold turkey, you will have also discontinuation syndrome. So it's not surprising. But that handled very well in hospital, and all of them were self-limited. Again, that caused Health Canada and the US FDA to issue a statement that says, among other things, consider stopping the drug before the end of pregnancy so there won't be a withdrawal syndrome. So postpartum depression is better than this syndrome, because the best predictor of postpartum depression is depression in late pregnancy. There's no discussion in any of these statements about those points. So that clearly, as one colleague said, clearly the people seeing these women were not consulted. Or in other words, the risk-benefit ratio. What's the risk of untreated depression? In our group, Adrian Ainerson and others showed that when women stop cold turkey, the antidepressants, they're hospitalized, they have suicide ideation, suicide attempts, and guess what? Some of them replace the SSRIs with alcohol. Not a great idea. There are high rates of perinatal complications associated with untreated depression, about twice the rate of miscarriages, higher rates of prematurity, probably, although not proven beyond doubt, associated with pituitary adrenal axis or with stress. But that's still in the work by many groups. And of course, it's the single strongest predictor of postpartum depression, which is life-threatening. So how come none of these statements that we saw in the last year never discuss these elements? Is this a responsible work by regulatory agencies? I will argue with you that it is not. And I believe if that happened in the auto industry with labeling, there will be a class suit within 24 hours. Someone will sue GM for saying something like this if it's not true, if it's true. So I think we have to create a new climate, that we take pregnant women no more seriously and we do more serious work that really balance risk and benefit. Don touched about women's differences, and I have to very briefly tell you there are many differences in pregnancy. Although people try not to treat women with medications in pregnancy, intuitively, you need more medication in late pregnancy. In late pregnancy, the clearance rate of many P450 drugs increase, so levels will be lower, necessitating more drug. That's true for fluoxetine, citalopram, and actually nicotine, as in nicotine patch, which is important for smoking cessation. Renally excreted drugs will have higher clearance rate, digoxin, lithium. There's higher hepatic blood flow, and of course, higher clearance rate due to higher expression of P450, not all of them, but some of them. I want to touch about the glyburide story as a very nice second example of pregnancy being a major issue. Don mentioned that one of the drugs that the OPRU system is studying is a hypoglycemic. It's glyburide. There is huge fear of using oral hypoglycemics because they cross the placenta and will cause neonatal hypoglycemia, which can be life-threatening. So for now, 30, 40 years, women with gestational diabetes, about up to 5-6% of women, who need therapy received insulin. Insulin is a large molecule not crossing the placenta, or minimally so. Insulin means injections. These are injections for women who did not have diabetes before. Many of them are not very happy to inject. Some cannot afford it. In third world countries, you cannot afford insulin in the paraphernalia. These are expensive. So there is a reason to see if we can learn more about the hypoglycemics. And about 4 years ago in a New England paper, Oded Langer, at that time still in Texas, showed that glyburide was as effective as insulin, but he could not find glyburide in the umbilical cord. You may ask yourself, who gave him permission to do it? Well, that was preceded by perfusion of placenta study, placenta perfusion, in his laboratory, 6 years before, showing that glyburide was not crossing the placenta. They did not know why, but it did not cross the placenta. We are working now on the mechanism of that, and it's probably example of a drug with huge protein binding. If you go to Goodman and Gilman, you will find very few drugs with so high protein binding, short half-life. And as we now show in our laboratory, one of our graduate students, Christelle Gideon, now showed that actually what throw the drug back from baby to mom is one of the ABC cassettes, the BCRP transporters, MRP. In other words, the placenta have transporters that can throw back some drugs into mom. Here is an example of a clinically important transport system. The same way we just showed with Denise Feig and a group in California, in Mount Sinai, that glyburide does not cross into breast milk. So again, not a reason to fear hypoglycemia. There are major teratogens, because I don't want you to get the impression that every drug is safe. The antipileptics, carbamazepine, valproic acid associated with NTDs, neural tube defects. Valproic acid just this year acknowledged to cause other malformations, not acknowledged before. Phenytoin, the ACE inhibitors, which are first-line drugs in non-pregnant patients with hypertension, cannot be easily used in pregnancy because of renal insufficiency and hypocalvaria, oligohydramnion in the baby. So here is some examples of drugs that will be of a problem. I want to talk briefly. The last model drug is the isotretinoin, the Accutane. Before introducing that into the market, it was clear already that Accutane caused 50% malformation rates. Several attempts to prevent women from taking it, both here and in the United States, by acknowledging physicians and warning women. The programs were perceived to have failed because pregnant women still continue to take Accutane. Actually, Accutane is not the right name anymore because there are 4 or 5 generics of Accutane with different names. So Accutane has a problem. It's a drug that is miraculous for acne, but it causes malformation. There was big debate at the FDA in the late 80s trying to ban Accutane. In a study that Motherisk did, we showed with American colleagues that in the 2000s already, women are still exposed to Accutane, and if you want to pinpoint one reason, it's really women's non-compliance and physicians' non-compliance. Women almost invariably told us they knew the drug is not good for them, but they failed contraception. That's again to the area of human behavior. The FDA just implanted a new program, I Pledge, in very short summary. Like the thalidomide, physicians and patients need to register now to get Accutane. In Canada, there is still debate. Health Canada has not changed yet the prevention program. However, and the Advisory Committee for Health Canada did not suggest to go the I Pledge. There is still discussion. I don't know it firsthand, but I read the literature. We believe, Motherisk believes, and we published that if the bottleneck are physicians, you should do something about it. There are other situations that we train physicians and demand certification. The biggest example, of course, is any physician who wants to give methadone need to have a course and certification. We believe that on a web base, physicians should take a short course what the prevention program entails. Basically entails 2 contraceptive methods in parallel if one fails, a woman understanding the topic, and women even signing, it's not really consent, it's not legally binding, but it's assent to do that. Another issue for you to remember, we are talking about active ingredients, but there are inactive ingredients. The inactive ingredients in which we put drugs are believed not to have pharmacological effect. But guess what? If you read carefully, a lot of the syrups you are taking have alcohol in them, some of them up to 40%. Do you think that's a good idea for a fetus? Probably not. Do you find any discussion about those? Never. Even if the dose of alcohol is not teratogenic, do you think that women want to take alcohol into pregnancy? Shouldn't we tell them that they take alcohol? So here is another area that needs to be addressed. Drugs in milk. If you read the Globe and Mail this morning, you read a case of a baby who was poisoned by his mom's milk. That because mom was ultra-rapid metabolizer, and I don't have the time to tell you the whole case, but she was an ultra-rapid metabolizer of codeine into morphine, producing levels 100-fold higher than the next woman, causing the baby to die at home. The physician who saw the child read the American Academy of Pediatrics saying that it's compatible with breastfeeding. Just to put it into context, in Canada there are 400,000 births a year. 20% of women have cesarean section, and they receive mostly Tylenol 3, codeine. This will translate, if this gene, ultra-metabolizer, is 1 to 5%, there will be between 800 and 4,000 babies exposed to an ultra-metabolizer mom taking codeine. And I don't have to tell you that not every death of a child in the first 10 days of age we have a reason for. In this case, we discovered it because a very astute department here that look at that. Our coroner just measure drugs. Most places do not, unless there is a suspicion. So in summary, there are many, many challenges to all of us, and the only way to change this situation is to take pregnancy as a challenge area or vulnerable field, similar to what happened in children, both in the United States and in Canada. Health Canada just announced creating an advisory group for pediatric drugs. I would urge and hope that the same is done for pregnancy, so we can move forward and ensure that in 206, women are not orphaned from the advantages of drug therapy. Thank you.